Drugs in the liver. Hepatic drug toxicity. Etiology, pathophysiology, and pathology. Drug-induced liver injury is a potential complication of nearly every medication, prescribed or non-prescribed, pharmaceutical or herbal, since the liver is central to the metabolic disposition of virtually all drugs and foreign substances. Damage can occur to hepatocytes, bile ducts, and hepatic veins, producing a range of clinical presentations, Table 47. The effect of drugs on the liver may be predictable and dose-dependent, e.g. paracetamol, but is more commonly idiosyncratic. Drugs can cause direct toxic damage, or indirect damage via the formation of reactive metabolites, which may deplete essential enzymes and cofactors, e.g. glutathione, paracetamol, or bind to liver proteins forming adducts. These adducts can subsequently mediate an immunoallergic response, e.g. autoantibodies to halothane and nitrofurantoin have been identified. Genetic factors are also important, e.g. deficiency in certain cytochrome P450 enzymes is associated with hepatotoxicity. Histological features depend on the type of drug, but in general drug-induced liver damage may be differentiated from other causes of acute liver injury by the presence of large numbers of eosinophils, Fig. 63. Epidemiology. The incidence of hepatic drug toxicity is underreported. It is thought to be 1 in 10,000 to 100,000. Prevalence increases with age, with drugs being responsible for 40% of acute hepatitis in those aged older than 50 years. Drugs most commonly implicated in causing drug toxicity include NSAIDs, paracetamol and dextropropoxyphene, clavulanic acid amoxicillin, Augmentin, flucloxacillin, amiodarone, statins, thiopurines, e.g. azathioprine. Heart, highly active antiretroviral drugs. Herbal remedies. Clinical presentation and physical signs. NB. Always consider drug toxicity in the presence of jaundice or abnormal liver biochemistry. Always ask about over-the-counter and herbal remedies, and check with the patient's GP. The clinical presentation depends on the type of liver injury. Jaundice, more likely if bile duct damage or cholestasis, but also occurs in severe hepatitis. Symptoms of hypersensitivity, fever, arthralgia, but these may be absent. Acute hepatitis, nausea and upper abdominal discomfort. Acute cholestasis, jaundice and itching. Fatty liver, usually asymptomatic. NB. There is usually a temporal association between starting a drug and the occurrence of hepatotoxicity, although liver biochemistry may become abnormal before symptoms develop. However, note that halothane and clavulanic acid amoxicillin hepatotoxicity occur up to 3 weeks after cessation of drug exposure. Investigations. FBC may show an eosinophilia. The pattern of liver biochemistry is shown in Table 47. Liver injury is defined as an ALT value more than 3 times the upper limit of the normal range, an ALP value more than twice the upper limit of normal, or a total bilirubin level more than twice the upper limit of normal if associated with any elevation of ALT or ALP. Liver injury is further classified as hepatocellular when there is a predominant initial elevation of ALT or as cholestatic when there is a predominant initial elevation of ALP. In a mixed pattern, elevation of both values occurs. Differential diagnosis. This depends on the type of liver injury caused by the drug. Acute hepatitis, viral hepatitis, autoimmune chronic active hepatitis, alcoholic hepatitis. Steatohepatitis, alcoholic hepatitis. Acute cholestasis, biliary disease, extrahepatic obstruction, intrahepatic disease, including primary sclerosing cholangitis, primary biliary cirrhosis and intrahepatic cholestasis of sepsis. Treatment. Stop the drug. Supportive care. Ursodeoxycholic acid is often empirically prescribed for those with a cholestatic injury. Complications. Acute liver failure. This is more likely in elderly people. It occurs in about 20% who are jaundiced. Overall, 15 to 20% of acute liver failure is due to drugs. Frequently reported with antituberculous medication. Chronic cholestasis. Loss of bile ducts, ductopenia, has been reported. Prognosis. In the absence of liver failure, most reactions are self-limiting with no chronic liver damage. If acute liver failure develops, outcome is not as good as that of viral hepatitis. Disease associations. In severe reactions, erythroderma, bone marrow suppression. Drugs in chronic liver disease. Clinical presentation. The following drugs should be avoided or used cautiously in patients known to have chronic liver disease. Narcotics and anxiolytics. Accumulation results in hepatic encephalopathy. Codeine causes constipation and secondary hepatic encephalopathy. NSAIDs may cause hemorrhage from esophageal varices and precipitate hepatorenal failure. Paracetamol. Small overdoses can be fatal, hence caution should be exercised if the patient has decompensated liver disease. Gentamicin and radiocontrast agents may precipitate hepatorenal failure. NB. Statins and liver disease. Post-marketing surveillance data suggest 1 case of liver failure for each million person-years of use, but there is no evidence of increased toxicity in those with pre-existing liver disease. Most guidelines recommend a baseline check of liver function tests before starting treatment, 8 weeks later and after any dose increase, then annual checks if tests are stable.